Micah Lewis. Excellent. Thank you. So I am a member of Neuropsychology, and we are really pleased that you could join us for this week's lecture in volume 10 of our Neuropsychology didactic series. This brings you lectures from experts in the field covering different topics every week. So it's exciting to know that you're here because our lecture helps us to give you a lot of information about the field. And this series was created by both trainees and early career neuropsychologists, which includes the standing members of the Neuropsychology Board who are here on this slide, as well as the various members of the Neuropsychology Committee, some of whom are with you all today. So before we start our lecture, one of the main goals of Neuropsychology is to provide free, high-quality didactic content to our audience, and every Neuropsychology and Neuroanatomy lecture is available on our YouTube channel, so be sure to check it out, subscribe, and like our lectures to get first access to any new content that comes out. New to Neuropsychology as well is our collaboration with Absent, which can bring you learning and discussion questions, which are provided with specific lectures contents, and you can access these through both our website and through Absent itself. Here are some of the disclaimers for this series. So this training is not meant to replace formal education in neuropsychology, and the views of the speakers that we have on this series are also their own. You can, throughout this lecture, submit questions via the Q&A box, which should be on the lower left of your screen, and a recording of today's lecture will be provided on both our website and on our YouTube channel later this week, so you'll be able to access the recording of this. Now, it's my pleasure today to introduce Dr. Kayla Arata for her lecture entitled Cognitive Prehabilitation and Rehabilitation in Neurosurgical Populations. So Dr. Arata is a neuropsychologist at the Cleveland Clinic. She completed her graduate training at Washington State University, her internship at Rush University Medical Center in Chicago, and her postdoctoral fellowship at the Seattle VA Medical Center. She specializes in administering neuropsychological evaluations to patients with epilepsy, and her current research interests include understanding epilepsy, understanding cognitive deficits across various epilepsy syndromes, evaluating the cognitive and quality of life outcomes following epilepsy surgery, and designing and assessing the efficacy of cognitive interventions for patients that have epilepsy. She's actively involved in national and international neuropsychology and epilepsy professional organizations, and we're very excited to have her here with us. So with that all being said, I'm going to stop sharing my screen so that Dr. Arata can share her own.
Right, thank you very much. Just getting my presentation pulled up here. All right. So as was mentioned, for today's talk, we're really going to be covering prehabilitation and rehabilitation techniques in neurosurgical populations. So first, we're going to cover prehabilitation. Now, this might be a new term to you, so we're going to cover the definition and kind of underlying theory to prehabilitation. And specifically, we'll be talking about prehabilitation as applied to delirium, neuro-oncology, and epilepsy populations. And then we'll spend the end part focusing a little bit on rehabilitation. I will say, I think neuropsychology has had a lot of really great talks on rehabilitation in general overall. And I think a lot of those talks discuss general rehabilitation strategies that can be applied to these neurosurgical populations, but we are going to at least talk just a little bit about how that looks like in the neurosurgical population and what the research shows in terms of efficacy of using rehabilitation in these different neurosurgical populations. As was mentioned, my specialty is mostly within epilepsy. So I'll be talking most about epilepsy, although I will try to wrap in some information and research related to brain tumor resections and some other neurosurgical populations. So before we delve into the details, I like to always take a step back and really think about the patient's perspective. As a neuropsychologist, I work with a lot of patients going through neurosurgery, and I think it's pretty easy to become desensitized to some of the stories. But I always like to frame cognitive intervention within the perspective of the patient. So throughout this lecture, we'll kind of be putting ourselves into the patient's shoes. So I want you to just imagine that you're at work and you suddenly go into a convulsive seizure. You're not a person that's been diagnosed with epilepsy. You've never had a known seizure before, so this is completely new to you. As a result, you're rushed to the hospital and you're given a bunch of tests to try to figure out what's going on. One of these tests include a brain MRI, and the doctors tell you there is a weird abnormality on MRI. There seems to be some kind of enlargement of your amygdala and your temporal lobe. These are all, of course, words and terms that you're not super familiar with, but it sounds very scary, understandably so. And then they start asking a lot of questions about really odd symptoms. And, upon asking you a series of questions, they realize that you've actually probably been having focal seizures for quite some time. You had just kind of chalked it up to maybe that they were just panic attacks. There were these kind of brief experiences that you had where, maybe you experienced a little bit of deja vu and went into almost like a panic attack feeling. Your anxiety ramped up, but it passed pretty quickly, only lasted a minute or two. So you really didn't think much of them, never really sought medical care for them. But in retrospect, after talking with a doctor that specializes in epilepsy, they say, actually, those were probably focal seizures. And what we think you have is focal epilepsy that generalizes to a generalized tonic-clonic seizure. And all of a sudden, you're told that you can't drive, you might not be able to return to work, or if you can return to work, you might be put on certain restrictions to go back to work because it's not always safe for people that have epilepsy to work in certain environments, to do certain job tasks that might be required of you. And so overnight, your life is now revolving around whether or not you might have a seizure, whether or not that seizure might generalize, and this weird abnormality mass in your brain that maybe it's a tumor, maybe it's something else, they're just not sure. So this is a patient perspective that I see on an almost weekly basis. So people in this situation they're often asked like, okay, what happens next? This is all just so new to them. For a lot of people, they're started on anti-seizure medications to help control their epilepsy. And that works for about 60 to 70% of patients. But there is a portion of patients, about 30 to 40%, that are eventually diagnosed with pharmacoresistant epilepsy. So this means their seizures are not being controlled by medications alone. And for those patients, particularly if they have focal epilepsy, sometimes they're considered for epilepsy surgery. If you're unfamiliar with the premise or basis of epilepsy surgery, the general idea is that we try to figure out exactly where your seizures are coming from and decide whether or not we can maybe take out that brain tissue that's causing those seizures to help treat the seizures. Now, epilepsy surgery is also not 100% effective, unfortunately. So anywhere in terms of effectiveness of epilepsy surgery, it kind of falls between 50 to 70% of people that have epilepsy surgery will have either a significant reduction in seizures or even become seizure-free. But there is still a portion of people who have epilepsy surgery and continue to have seizures. So it's a lot of times comes really down to weighing the risk benefits. Although surgery is not 100% effective, the problem is the only other treatment is medications. And once someone's been labeled as pharmacoresistant, the likelihood of medication adjustments controlling their seizures is often less than 5%. So many times you're left with this decision: try more medications and 5% chance that something will work, or go forward with epilepsy surgery and increase those chances to anywhere between 50 and 70%. So you can see how this would be a really big decision for anyone in that position. Now, let's say in this situation, anti-seizure medications aren't enough, you're being considered for epilepsy surgery. So what does that look like? Well, first, you're ran through a bunch of tests. So our pre-surgical workup process is very extensive. Usually this requires a multiple day stay in the hospital. So people come to the hospital for 5 or so days, give or take a few days. And they'll do things like be hooked up to an EEG, have video cameras pointed at them to capture a seizure on video, and often will do different things to help provoke a seizure, like reduce your anti-seizure medications, expose you to bright strobing lights, restrict your sleep, etc. And then you're told to go through things like MEG, PET, ictal SPECT, another MRI, neuropsych evaluation. And it can be a pretty overwhelming process, as you could imagine, right? So there's a lot that goes into this. Then what happens? So we collect all this data on our patients. And usually what happens from there is we have what we call at the Cleveland Clinic a patient management conference. This is where epileptologists, neurosurgeons, neuropsychologists, social work, psychology, psychiatry, everyone that's a part of the epilepsy team at that center ends up attending patient management conference to talk about different patients and whether or not surgery is a viable option for them. And then in the patient's shoes, they just have a follow-up appointment with their epileptologist that summarizes this information and gives a final recommendation. So again, putting us back into that perspective, let's say that surgery ends up being a possibility to treat these seizures. And so the recommendation is to proceed with epilepsy surgery. But with surgery comes risks. Fortunately, things like risk of mortality or serious complication during surgery is pretty low when it comes to epilepsy surgery, at least, and a lot of these neurosurgical interventions. But often one of the biggest risks is related to cognitive function. So, for example, for someone that might have maybe an abnormality or mass in their left temporal lobe, they might be at a 45% chance of experiencing a change in memory or language functions with epilepsy surgery. So now you might have this very viable treatment option that sounds like it's the better option compared to medications, but are you willing to lose your memory ability? Are you willing to have maybe language difficulties? And what will that actually look like? And the hard thing here is these discussions tend to happen in an appointment that's about 30 minutes long. And so for a lot of patients, this can be a really difficult decision and not one that they have a ton of information necessarily going into making it. Now, of course, they trust their team, hopefully, and they know that the epileptologists and the rest of the epilepsy team is hopefully looking out for their best interest, but it gets complicated, right? And in these cases, usually surgery is just, once you say yes, surgery is scheduled. And there's really nothing in the interim to help prepare patients for surgery. So in comes prehabilitation. So prehabilitation is when we address modifiable risk factors during the pre-surgical period to help reduce post-operative complications. Now, this was originally used outside of the cognitive neuropsychology world. One example of this is for bariatric bypass surgeries. A lot of times, folks going through that type of surgery have a difficult time adjusting to the diet recommendations following bypass. So what they started doing is a form of prehabilitation related to diet and nutrition to try to get the person to learn and practice really healthy eating habits so that they were more prepared to cope with the adjustment after their surgery. And that seemed to be really effective. And so once we started getting this sense that we can actually do things before surgery to help limit those post-op complications and that post-op adjustment period, that's when we started thinking, could this be applied to brain health or cognitive health? So the primary application in terms of cognitive rehabilitation has been primarily applied to reduce delirium or post-operative, more longer-term post-operative cognitive changes for elective neurosurgeries. And we'll talk about these a little bit more. But there's a lot of different forms of rehabilitation out there. And I think the research is really still trying to understand exactly which forms are most effective or which combinations of these different mechanisms of action are most effective. So some of the things that people have tried that you'll hear mentioned are things like brain training. So this is the idea is if we exercise our brain before neurosurgery, perhaps it will be more resistant and help heal after surgery, right? There's been rehabilitations that have focused really on brain health. So again, targeting things like diet and exercise to try to promote brain health before surgery to help it be a bit more resistant to any changes following surgery. Some rehabilitation focuses on compensatory strategy use. The idea being, if we know that you're going to experience a cognitive change with surgery, maybe you can start developing really good habits of using a variety of cognitive compensatory strategies so that should you experience that change, you're already well equipped and have good routines and habits in place so that that change won't be as functionally limiting or impairing. Some cognitive rehabilitation focuses on actual reorganization of cognitive functions, and we'll talk specifically about this a little bit more. And then some cognitive rehabilitation just simply focuses on giving the patient a little bit more education ahead of time. Like I said, a lot of these discussions about surgeries and elective neurosurgeries happen at a very brief appointment. And yes, the patient can go look up information and are provided, pamphlets or other like written information. There's often a limited amount of psychoeducation that's given beforehand. So some cognitive rehabilitation is just about giving more education to the patient. So let's first talk about how this was applied to delirium. This is not really specific to the neurosurgical population, but I want to mention it because it does have some of the most research about it in regards to cognitive rehabilitation, although I should say this as just kind of a blanket statement. Research on cognitive rehabilitation is in its infancy. This is a very much like emerging field, so we do not have a ton of research in general about it. So if you're not familiar with what delirium is, this is a sudden, usually short-term change in attention and cognition. It usually presents as general confusion, and this is a common post-operative complication. It can occur anywhere between 12 and 50% of surgeries, and this is not specific to neurosurgery. So this is any type of surgery, cardiac surgery, orthopedic surgery, any type of surgery. Delirium can be a post-operative complication. And we specifically see higher rates of delirium in older adults. So in comes rehabilitation for trying to prevent delirium because it is such a common and complicated post-operative secondary effect. So there's been several forms of rehabilitation and delirium that have been proposed. We've looked at how exercise and nutrition rehabilitation might impact delirium. And there have been a few studies that have showed decreased rates of delirium for those that are exercising routinely and eating well prior to their surgery, with some of these specifically looking at programs that promote these brain health strategies ahead of time. There's been several studies to look at how brain training might prevent delirium. So the idea being again, exercising that brain to make it more resistant to any change, right? And so this is usually comes in the form of brain training games like apps that you can even commercially, sometimes are commercially available. This has had a little bit more mixed evidence, I would say. So for example, there was one randomized controlled trial that showed that brain game exercises didn't seem to impact delirium risk in cardiac patients. But then a year following that, there was another randomized controlled trial that said, actually, we did find them to be effective in non-cardiac surgery. And in this particular study, they found that rates of delirium decreased from 23% to 14% in those that did more brain training games before surgery. So that's all to say there might be something there. I think it's still out a little bit in terms of how effective it is, or perhaps what populations it's going to be most effective for. There are several education programs for prehabilitation and delirium as well. And so these programs are usually focused on providing education, usually to the patient as well as caregivers or families, about delirium risk factors, about ways to prevent delirium, and early detection of delirium. And these education programs have been shown to be to have a lot of positive effects in terms of preparedness, satisfaction, and that early detection of delirium, so better treatment of delirium. So overall, what we kind of see from this body of literature is that there might be something there, right? That it does seem like having a healthier, more active brain that is well equipped and prepared with information seems to have a positive effect on a variety of outcomes with different surgery complications. So this, like I said, this is kind of the early body of literature to suggest that there might be some forms of cognitive rehabilitation specifically that could be effective. But often what we're worried about in my world is not delirium. It's not those transient fluctuations in cognitive function that occur right after surgery. Usually what I'm most worried about with patients that I work with are more long-term post-operative cognitive changes that come from the fact that we've removed brain tissue that control important cognitive functions. So this comes up the most in brain tumor resections and epilepsy surgery. Now, in terms of the frequency of this, I would need a whole nother lecture to really cover this in any level of detail. But with brain tumor resections, often the likelihood of cognitive change is very dependent on the specific type of tumor, location, and any follow-up treatment the person might have, like radiation, chemotherapy, etc. With epilepsy surgery, we see the highest rates of long-term cognitive changes in temporal lobe epilepsy specifically. And temporal lobe epilepsy is one of the most common forms of epilepsy, of focal epilepsies, and happens to be one of the most common forms of epilepsy surgery because of that. So essentially, the most common form of epilepsy surgery comes with some of the highest cognitive risks, with rates up to 45%. And usually what we see in temporal lobe epilepsy are changes in memory and an increase in word finding difficulties or having problems with that tip of the tongue issue. Now, there are other forms of epilepsy surgery, and those can come with different levels of cognitive risk. Again, can't go into detail here because that's a whole nother lecture in and of itself, but just know there is a variety of cognitive changes that can happen, but temporal lobe is the surgery population that we're usually worried about the most within the epilepsy world. Now, in terms of surgery, patients usually show the biggest cognitive change right after surgery. Unfortunately, people tend to show their biggest recovery within the first few weeks to few months after surgery, although we know that recovery can even persist up to a year after surgery. And so this recovery process can be quite lengthy, but the bulk of it does happen fairly shortly after surgery occurs. And so a lot of times what we're worried about is trying to identify those that first are going to be at a high risk of experiencing some cognitive change with surgery, especially those that might have more persistent cognitive changes, and trying to understand how that might affect them. With these elective surgeries, this is often goes back to the idea of informed consent, because we need to let the patient know that there might be this risk or this change. And for me and a lot of the conversations I have, usually we talk about this within the context of the patient's goals. So for most patients going through these types of surgeries, it's to alleviate the condition. So in epilepsy surgery, they want to alleviate their seizures. That's why they're considering surgery. But what's the secondary impact of that? Are they hoping to resume driving? Are they hoping to get back to work? And is a cognitive change going to impact those secondary goals, right? So in the more kind of long-term post-operative cognitive changes, I'm going to first talk about a form of prehabilitation that's been specific to brain tumor resections, and then talk a little bit more about epilepsy prehabilitation. So within the brain tumor research, there's something called neuromodulation-induced cortical prehabilitation, or NICP for short. The underlying theory here is that perhaps we can train cognitive functions to be reorganized and managed by other areas of the brain that are not located near the tumor. So if a tumor is in a specific location where we think that it's likely controlling important cognitive functions, can we get the other areas of the brain to take over those cognitive functions before surgery? In general, we know that there is some cortical reorganization that can happen after surgeries like this, or after injuries like traumatic brain injuries, strokes, etc. So we know that the concept is there, but can we actually preemptively do this is the question here. So how they do this is they first deactivate the tissue around the brain tumor by using neurostimulation. There's various forms of neurostimulation, but essentially what this stimulation does is it turns off the ability of that brain tissue to do anything. So all of its functions that it controls, it turns off when it's stimulated. So the idea here is we'll stimulate it and turn off this brain tissue that we want to take out anyways. And then we have the person do really intense cognitive exercises to basically activate other areas of their brain to get it to take over these other important skills. So I think that this is a fascinating idea and concept, not one that I have any personal experience in doing, but I will say that the research is very, very early. So there have been a few case series that showed that with this type of NICP, we can see some shifting of functions on fMRI. So these were some of the earliest studies to show a proof of concept of sorts. There was one pre and post-op case series that did actually formally use this type of therapy and test patients before surgery and after surgery. And what they found is that patients did seem to have improved motor and executive functions, but they didn't have a control group. So it's kind of hard to know exactly the effect of that and the impact of the actual intervention in and of itself. So right now, again, research is very early on, very small sample sizes have really only been tried. This type of rehabilitation has only been tried on a limited number of patients. So it's showing that maybe there's some underlying utility to the theory and that maybe it's a possibility, but we certainly need more research to better understand this. And I've never seen this concept applied to epilepsy, although I think it, could have the same sort of implications and idea behind it. So in terms of prehabilitation with epilepsy surgery, primarily what has been talked about is giving patients education and cognitive compensatory training prior to epilepsy surgery. Sally Baxendale is a researcher in the UK that was really the first person to write about the concept of cognitive rehabilitation as applied to epilepsy. But since then, there have been no formalized treatments or manualized treatments that have been researched. But the idea is that if these are patients that are at risk of experiencing a cognitive change, let's get them to form really good habits and routines prior to surgery, because they're going to be more successful at behavior change before any additional cognitive losses, right? And so let's get them to practice these different strategies ahead of time so that should they experience a big shift in cognition after surgery, they already have the tools and are well equipped to adjust for these changes so that it doesn't have a significant functional impact. And this is where my research has come into play. So I am currently researching what is called the Readiness Brain Operation Optimization Training, or REBOOT for short. And this is the first manualized cognitive rehabilitation program in epilepsy. This research is early stages as well. So I'll present some hot off the press data, but we are still actively recruiting for this study. So we're still collecting data, and again, in the early phases because of that. But I'll tell you a little bit about the program just so that you can kind of see how prehabilitation can work within the epilepsy setting. For REBOOT, we meet with the patient through 6 virtual sessions. Virtual is very important for the epilepsy population. Most of these people cannot drive. And here at the Cleveland Clinic, very few patients are actually from the Cleveland area. So this program's done entirely virtual. Again, it's 6 sessions. 2 of the sessions are one-on-one with me. So the first session is a one-on-one to orient the patient to the program, but also just to talk about their surgery in general. And I made this one-on-one because I think it's because there's so much variability with epilepsy surgeries and cognitive risk. I really wanted that to be individualized to the particular person, right? And so we talk about their surgery that they're going to have, their cognitive risk with surgery, what they kind of already understand and know about that, or if they have any other questions about that. And then we think about what's their life look like? What are their current goals for surgery? And how might any cognitive changes impact those things? Because that's really setting the foundation for understanding whether we can develop some good habits and compensatory strategies to help adjust for any of those potential changes, right? And then they have 4 group sessions. So these group sessions are actually done with other people that are going through the pre-surgical process. And I will say, I think this is one of the most important parts of the program, having several patients go through this program. They really appreciate getting to meet other people going through epilepsy surgery, because as you can imagine, it's a very unique experience and not a lot of people can relate to it in any way, shape, or form. So it's really helpful for them to have some peer support as well. Through these rotating group sessions, they're called rotating because they can jump into them and out of them at any given time. That's particularly important for this patient population because a lot of times there's very limited time between when they make the decision to have surgery and when surgery is actually scheduled. So we wanted to make sure that people could get through the program quickly enough so that we weren't basically up against a surgery date and they weren't able to finish, right? So they can jump in at any time. And through the group sessions, we cover different cognitive compensatory strategies by different cognitive domain. So one week we talk about memory in general and memory strategies. One week we talk about language and language strategies with a heavy focus on word finding difficulties because that's the most common language change with epilepsy surgery. And then we also talk about attention organization and strategies related to that. And then the last group session focuses on brain health. And this has a heavy emphasis on things like diet and exercise to really promote good brain health for recovery as well. And then the last session is another one-on-one with me, where we emphasize everything, kind of recap everything that we discussed as part of REBOOT. But this is also a session where we just talk a lot about general preparedness for surgery. A lot of times by the time we're having this wrap up, they're only weeks out from their surgery, and they might still have some remaining questions about what will recovery look like. We actually go through and make a recovery plan, because that's not something that patients always think about ahead of time. They're just so focused on surgery and so nervous about surgery, which is completely understandable. But then once they get to the recovery, they're kind of like, oh, wait, I completely forgot to think about this part of it, right? So we make sure to talk about recovery, and we talk about it in a more holistic sense, not just cognitive recovery. For a lot of these patients, they'll experience mood shifts. They might experience something that's called the burden of normality, having difficulty basically going back to a normal life after epilepsy surgery, especially if they suddenly go from a state of being chronically ill because of their seizures to being all of a sudden completely well, or what is perceived as completely well. And so there's a lot of things that go into this recovery process, and we spend some time discussing those things so that the patient can be prepared for that. So this is just a little sampling of the REBOOT manual. So you can see how there's a lot of education components to it. The last page here is the recovery plan, and really, trying to be thoughtful about ways to help with the recovery process and what to expect for surgery. As I mentioned, the program is heavily focused on cognitive compensatory training. And so with that, we have a goal setting component where they make a new goal every week to use a new cognitive compensatory strategy. So they are actually trying these things out. And then every next week, we check in about that goal, whether they were successful, whether we need to modify, whether we need to adjust, etc. And then they're also given a cognitive toolbox as part of the REBOOT manual, where we just talk about general cognitive strategies. So as of now, we have 26 participants actively enrolled in REBOOT, and it is a randomized control trial. So as of those current numbers, 15 patients have gone through the intervention, 11 patients have been placed in the control group. Part of this initial study was just to really look at the feasibility of doing a prehabilitation program in epilepsy. So we have had 3 people withdraw from the intervention group, but it was for reasons like surgery was scheduled too soon. They were no longer recommended to have surgery. And then one participant just didn't want to complete the questionnaire. So, so be it. But we have been tracking attendance for those who complete the REBOOT program. And for the most part, patients have 100% attendance. There were 2 patients that had to miss one session each. And that was just because of, scheduling issues, life, it happens, right? So as of now, all I've looked at is just general satisfaction for the patients who have gone through the REBOOT program. I'm still waiting for the other data to come in. But at least what we've found so far is that patients really do feel like REBOOT is beneficial. They feel satisfied by the information that's covered. They generally think REBOOT's enjoyable and effective and helps increase preparedness, and overall would recommend the program to other people going through epilepsy surgery. So far it seems like people are very receptive to this program. We're collecting a little bit of qualitative feedback from these patients, where they're, throughout the program, they tend to give me feedback just verbally, but we also ask them via questionnaires what they thought about the program. I'm not going to read all of these comments, but the 2 primary themes that I see in this qualitative feedback is, 1, patients really appreciate having more education and having the opportunity to ask questions and go through things. The second theme is support. So patients really appreciate being connected with other patients going through the surgical process. Another thing that we do as part of REBOOT, I forgot to mention this earlier, is we actually give them the option to be connected with someone who's already had epilepsy surgery. And most of the patients do take advantage of this. I think all but 1 patient has agreed to talk with someone that's already had epilepsy surgery, and they found that really helpful. And in fact, I know that a few of them just over time after they had epilepsy surgery, they've stayed connected to that person that they were connected with initially because they really appreciated that support. And I think it's a really positive thing for them. The other thing I would like to point out is that for each of those 6 sessions, we have the patient complete a brief poll immediately after the session to rate how much they like the session or different aspects of the session. And when we look at which session is the most highly rated, it's actually that last session, which I find a little ironic because the last session has pretty much nothing to do with cognition, but it has everything to do with general preparedness and the recovery plan and the details of surgery and what's going to happen there. And so I really think people benefit from that education recovery planning model. And with that, I will say that in general, the more that we've thought about the layout of these neurosurgeries and the neurosurgical workup process, the more we realize how important education really is. So when we think about surgical satisfaction following brain tumor resections or epilepsy surgery, a lot of things that go into surgery satisfaction is not just whether or not the treatment was successful. A lot of times our medical world is very much focused on diagnosing, treating the condition, and then as long as the patient, for example, is no longer having seizures with epilepsy surgery, it was a success, right? Done. But the fact is that patients can have seizure freedom and still be very dissatisfied with surgery. And I see that multiple times. So when we think about other factors that influence that surgical satisfaction, there's things like the patient having appropriate expectations for surgery, having good informed consent of the risks and benefits of surgery, having sufficient support while they're going through the surgical process. And so this is why there is just starting to be emerging programs that are focused on surgery preparedness. Now, this isn't necessarily new to the surgery world as a whole. If you think about liver transplants, kidney transplants, bariatric surgeries, a lot of those surgical centers already have these pre-surgical preparedness programs as part of the process. But with neurosurgery, not so much. We just haven't done a good job. This has not been a priority within the field. And I really think that that's something that needs to change and be evolved. And here at the Cleveland Clinic, we are currently working on putting together a program that actually just really focuses on that education and peer support component for patients who are going through that surgical process. So bringing it back to our perspective taking exercise, putting ourselves back into the shoes of a patient. Let's say you end up saying yes to epilepsy surgery and you end up having surgery without complications, which is great, right? But you do notice that after surgery, you're just having a little difficulty finding the right word to say. You feel like your memory's not clicking as well as it used to. So you are noticing some very mild cognitive changes. Now, hopefully you had good informed consent and you knew that this could happen, right? But now what? Now what do we do? Now that there's been a change after surgery? There's usually a few different pathways that people take after these elective neurosurgeries. So for those that experience a really significant cognitive change, the first thing might be to assess for delirium or other post-operative complications like a hemorrhage that's occurred during surgery. And of course, if that's the case, they'll treat that complication first and foremost. But for some people, they might have fairly significant cognitive change after surgery. And this is often coupled by like motor changes and maybe other like sensory changes and things like that. This might be a patient that has a brain tumor that's in a location that just controls a lot of functions, right? And so in those cases, sometimes inpatient rehabilitation is an option and is offered to the patient. Within epilepsy surgery, I can't think of I think maybe I've seen one patient that has actually gone in inpatient rehabilitation. I would say for the majority of epilepsy surgeries, things are handled on an outpatient basis. So in our example, our perspective taking example, this would be kind of more under the umbrella of experiencing some more mild cognitive change. And so typically what would be recommended is the patient would have a 6-week post-op visit. And if they were still experiencing some bothersome cognitive changes, the doctor would then order something like speech therapy or recommend another form of outpatient rehabilitation, although those are pretty limited, if not non-existent. And then for the really lucky ones, they have no cognitive change and no follow-up treatment, and all is well. And hopefully they're seizure-free, or they were able to resect the majority, if not all, of the brain tumor, right? So when we think about rehabilitation applied to these neurosurgical populations, and really generally, usually there's two forms or aims of rehabilitation. One is to try to recover the cognitive function by training it. The other is really focused more on compensation of the deficit and saying, we know that this deficit is probably going to be long-standing, so how can we compensate for it, because we're not going to recover it. In some surgeries where there is a pretty significant cognitive change, the initial treatment is focused on that recovery of function. But for a lot of surgeries, especially with epilepsy surgery, there's more so an acceptance of the fact that a lot of these cognitive changes might be more longstanding, so the compensation route might be more advisable. But this can obviously vary from patient to patient and situation to situation. And sometimes these two things can be used together, right? These two aims. When we look at the research literature related to rehabilitation in brain tumors, we find that there's very little research on it, the theme of today's talk. So there was one research or review article, and they searched different manuscripts from 1997 to 2015 and only found 7 studies that looked at rehabilitation in brain tumor resections in particular. When you look at these different studies, there was a pretty equal split between the programs focusing on cognitive retraining versus compensatory strategy use. But they did find pretty promising results in that some people who underwent these programs did experience improved memory and attention and generally had good patient satisfaction. Now, in regards to limitations, the one difficult thing with the brain tumor population in particular is that sometimes there's a pretty poor prognosis. So even though they might be taking the time to resect that brain tumor, people might only have a few months to a few years of life expectancy after that surgery. So a lot of times what's considered in these situations is really the time and effort that it takes to participate in rehabilitation and whether or not it's worth it. But I will say the studies that have looked at this, they have found that quality of life is improved in people that go through these rehabilitation programs. So they argue that even though life expectancy might be limited in some of these patient populations, they still reported satisfaction because they felt like it helped with their quality of life as part of their treatment. And that's really important, right? But again, very limited research, very few randomized controlled trials looking at these interventions, and the few that do exist have very small sample sizes. Now, rehabilitation in epilepsy also exists, but again, very minimal. One review article from 2015 looked at all of the studies between 1974 and 2013 and only found 10 studies that looked at cognitive rehabilitation in epilepsy. Now, most of these interventions really focused on compensatory strategy use. There were a few interventions that incorporated a brain training component, something like lumosity and practicing that on a regular basis. However, those studies that did look at a brain training component, they had follow-up studies to see whether the brain training component actually had an additive effect beyond the compensatory strategy training. And they found that the brain training did not have an additive effect. So important to keep in mind. But they did find that compensatory strategy training did generally improve memory and quality of life. Although, again, small sample sizes, and most of this research has been on mixed groups. So most of these studies have been done on patients that have and have not had surgery. They're just all mixed together. So it's unclear about this particular effectiveness after surgery specifically, right? And again, lack of randomization, lack of control groups tend to plague this type of research. And a lot of these studies or a lot of these programs don't have lack of replication because they're not manualized. There is one manualized treatment. It's called hopscotch that has been validated within the epilepsy population. It's not specific to surgical patients, although some of the patients included in the research have had surgery. And so we do have one manualized treatment for cognitive rehabilitation in epilepsy, and that's the hopscotch program from Dartmouth. And at Cleveland Clinic, we're also doing some research on this as well, in particular looking at a group-based cognitive intervention for folks with epilepsy, but it's not specific to the surgical population. So that is all I had for you today. In conclusion, we know that prehabilitation is really an emerging field, and it seems to have promising findings, but it's very, very, very early on. But I do really like this idea of preventative medicine, where we're actually trying to prevent something rather than react to a complication. And I love how prehabilitation, and the thing that I've really enjoyed working with patients personally, is the fact that it considers the whole patient experience. It does not just consider the disease, the treatment, and disease outcome. It considers the fact that this patient has gone through a lot, the pre-surgical process is a lot, and how can we help support them through that process? We also know that rehabilitation is generally effective treatment after these neurosurgeries for folks that do experience post-op cognitive changes, although again, manualized treatments are difficult to find and not well researched. So we really need more RCTs, and we need larger sample sizes and more manualized treatment programs to really increase this field of research. But this is really complicated when you're working with patient populations that are pretty heterogeneous and might need more tailored interventions of sorts. With that, I am happy to take any questions.
Excellent. Thank you, Dr. Arata. I have a few questions from members of the audience. So from Cecilia Hahn, they asked, other than patient satisfaction, how do you plan to study the outcome and effectiveness of the program that you've developed at the REBOOT program?
Yeah, that's a great question. So for patients who go through the study, whether they're in the control group or intervention group, they're asked to fill out questionnaires when they first enroll in the study, after the intervention, which is about 6 weeks later. And then we also are following them after surgery. So they're asked to refill out these questionnaires 6 months after surgery and 1 year after surgery. Our main outcome is a quality of life questionnaire, the Quality 31, that's very commonly used in epilepsy research because it is one of the most well-validated questionnaires in epilepsy. And so that's really our primary outcome is, does this actually improve quality of life outcomes post-operatively? But I need all of those patients that are currently enrolled in the program to actually have surgery and then be 6 months out of their surgery. So you can tell that this is a very long-term study, right? Secondary outcome is also related. So we also have questionnaires related to increased compensatory strategy use, increased self-efficacy, increase or changes in mood, and general surgery satisfaction. So there are some secondary outcomes included as well.
Amazing. What types of measures or batteries are you using for the pre-surgical neuropsychological evaluations? Are you tending to use a more specific or a flexible battery approach?
Yeah, so here at the Cleveland Clinic, we have a standard battery that we give the majority of our epilepsy patients. Now, the standard battery is assuming temporal lobe epilepsy because that's the majority of patients that we see. We might add in or subtract some tests if it's a different form of epilepsy or surgeries occurring in like the frontal lobe or the parietal lobe, et cetera. So there is some flexibility attached to it, but we generally have a standard battery. For those of you who may be newer to the field of neuropsychology, it's historically epilepsy batteries are some of the longest clinical neuropsych evals that exist out there. And so we tend to test our patients like crazy. Here at the Cleveland Clinic, we really have tried to parse that down from a data-driven approach. So we actually took time to look at our clinical database that includes over 3,000 patients at this point, and looked at base rate impairments across patients on those different tests that we're administering to try to narrow down what tests aren't really giving us that useful of information. So I would say in comparison to a lot of centers, the Cleveland Clinic epilepsy battery is one of the shorter ones, but it still is long in the world of neuropsychology.
That's amazing. Um, Someone asks, will prehabilitation treatment be approved and covered by insurance?
That's such a good question, and I wish I had a good answer for you. I think it's something that the US medical system in particular does have a hard time with because it does tend to be more of a preventative medicine route, which we know insurance here does not like to fund. This is part of the reason why prehabilitation has been primarily studied, or not studied, but utilized clinically in Europe and Australia. Those are the two kind of big groups within the epilepsy world that have done a lot of this work clinically. And it's because they can actually get it covered. They don't have to worry about, US insurance stuff. So I think it can be done. The thing with our epilepsy patients is the majority of them do show cognitive impairment even prior to surgery. So we can still use traditional cognitive rehabilitation codes for a lot of those folks. But right now, I've just applied it research-wise, so I don't know the acceptance rate from insurance. So I think that's something that, is something to be discovered in the future.
Appreciate that. When you're considering who to recommend complete epilepsy surgery, can you speak to some of the ethical challenges when you're determining if someone is a good candidate or, not the best candidate to go on for epilepsy surgery?
Yeah, that's a great question. So we are very fortunate here that we actually have bioethicists on our epilepsy team that help us with all of the ethical dilemmas. I think the biggest ethical dilemma that comes up are patients that have pretty significant cognitive impairment prior to surgery and whether or not they're competent to make that big of a medical decision on their own, and or whether they should have guardianship applied to help them through making that decision. There are also some patients that we think as being very high risk for complete amnesia following epilepsy surgery. And I think in those situations, the cognitive risk is weighed much heavier. But it really usually comes down to informed consent. And so that is the onus of that conversation is primarily on the epileptologist, although everyone involved in the patient's care obviously has similar discussions, but it's really kind of weighing the risks and benefits. But if the person doesn't seem like they can make that informed decision on their own, that's when we might get bioethics and social work involved in terms of how to proceed forward.
Amazing. When we're thinking about people who have completed the surgery, are there any, in-person or virtual post-surgery support groups that you might recommend to people? Any that kind of internationally or nationally that people might benefit from joining?
Yeah. So place that I recommend the most, which is biased because it's local to Cleveland, it's called Empowering Epilepsy. But this organization is expanding to national representation. So they are growing quickly, and they have a lot of support groups that are offered virtually. Now, their support groups are broken down in age groups, which I really appreciate, because I think someone that's 20 something with epilepsy has a very different lifestyle than someone who's 60 something with epilepsy. But it's not broken into people who have had surgery or haven't had surgery. It's just a mixed group of people. But I do think that there's a lot of support that can be gathered in their support groups. Most of them are offered virtually. And the few that I've joined, there's a pretty national representation of the people who participate in those virtual support groups. But there are other organizations out there through different national organizations, through the Epilepsy Society that also offer virtual support groups. So there's plenty of support groups out there, but Empowering Epilepsy is probably the one that I recommend the most. They also have a annual Empowering Epilepsy Conference, which is coming up this Saturday, and an annual brain surgery conference that occurs usually in the summer, like around June. And so that's really great for patients with epilepsy to attend as well.
I love that plug. So for anyone that's local to you in the Cleveland area, that sounds like an interesting thing to get up to in the next week or so.
And the
It
conferences
is
are all virtual, so you can have patients join them.
amazing. It is 5:03, so I do want to be conscious of timing for anyone. So if anyone wants to have another question that gets asked, recommend that you pop it into the chat right now or into the Q&A. So we'll give about maybe another minute for anyone to enter any final questions. And then otherwise, we will plan to wrap up. And I also want to make sure while people are still present that I'm giving my own plug for the upcoming talk that's happening next week. So that'll be happening on October 21 at 2 p.m. Eastern Time. And that'll be on pediatric solid organ transplantation and failure with Elise Turner. So for anyone that wants to join that talk next week, that'll be upcoming. I'm not seeing any other questions. So what I'll do is I'll have us end here. So thank you, Dr. Arata, for speaking on this amazing topic and sharing all of your information with us.
Thank you for having me. Have a good day, everyone.
Thank you all for joining.